Good morning, good evening to everyone, wherever you are. Welcome to this joint webinar of the Public Health Foundation of India, the Harvard Medical School for Global Health Delivery, and the Massachusetts Consortium of Pathogen Readiness, or MassCPR. Welcome to this webinar, which is second in the series of such a seminar. The first one had a very eminent panel. This particular webinar is focused on the multidimensional challenges of and opportunities of treating COVID-19. So we are in almost the 7th month of the pandemic, and we have seen several ups and downs, and we are just getting a bit of hang on the pandemic itself. This is one of the biggest challenges for humankind after the Second World War, and in fact, it will remain as one of the most significant pointers in history, and how we come out of it is what is going to determine our future. When I was a medical student in the 1980s, we were told that if you learned tuberculosis, you would have learned everything in medicine. As we moved along, tuberculosis decreased and we started having chronic diseases, and it used to be said that if you knew diabetes, you would know most of medicine. But I think we can say about COVID-19 the same. If you know COVID-19, you know most of medicine, because it has varied manifestations, unexpected outcomes, unexpected presentations, and so on and so forth. In order to discuss what has happened so far and where we are going, what we can do about this, we have really two eminent speakers today. The first speaker will be Dr. Rajesh Gandhi. He is a professor of medicine at the Harvard Medical School and director HIV Clinical Services and Education at the Mass General Hospital. So I hand over to Dr. Gandhi to give his perspective on this challenge. Dr. Gandhi.
Yes, thank you very much. It's great to be here. Thank you to the organizers for putting together this webinar. And I'll spend the first 20 minutes or so talking about the multidimensional challenge and opportunity of treating COVID-19. So the way I think about this particular problem is in several dimensions. I think first about the host that we're treating. Are we treating an adult? Are we treating a child? And what are the particular individual's risk factors for severe COVID-19? Secondly, I think of the stage and the severity of the disease, and we'll come back to this multiple times over the course of the next 20 minutes or so. Is someone early in the infection? Are they late in the infection? Do they have mild, moderate, severe, or even critical illness? And then lastly, I think of the intervention being deployed. Is it an antiviral? Are we trying to modulate the immune system? Are we using a combination, or are we trying to treat one of the complications of COVID-19? So this slide shows you the range of manifestations of COVID-19. I fully agree that if one knows COVID-19, one really knows the breadth of medicine. Although it is primarily a respiratory illness, we've learned in a few short months that it can involve neurologic complications, including strokes. It can involve cardiovascular complications. We've seen patients present with myocarditis, with heart failure, renal failure. Gastrointestinal manifestations can be early on, including diarrhea, abdominal pain, but also elevated liver enzymes. Skin manifestations, the so-called COVID toes, and then finally systemic manifestations. And these systemic manifestations really range from thrombosis, inflammation, and a multi-system inflammatory syndrome. Here's just one slide showing us the link between thrombosis, inflammation, and mortality. In early data out of China, the coagulation and inflammatory biomarkers shown here, D-dimer, interleukin-6, CRP, these were all associated with greater likelihood of mortality. So elevations in these particular markers tracked strongly in the context of severe disease with mortality. And I put in one slide, I think, to really bring this home, which is the pathology of COVID-19. This is a study that was in the New England Journal of Medicine a few weeks ago, looking at the lungs of people who died of COVID-19, compared them to the lungs of people who had influenza, or the lungs of people who were uninfected and died of unrelated causes. And what you can see in the photomicrographs here are really the presence of pronounced endothelial injury, the presence of widespread thrombosis, microthrombi, and then intussusceptive angiogenesis. So this really is a disease, as was mentioned before, that's multisystem, that involves multiple organs and the vasculature. Now in children, there is a distinct manifestation called the multisystem inflammatory syndrome in children, or MISC. This appears to be an acute vasculitis with similarities to Kawasaki disease. Children may present with fever, rash, conjunctivitis. They may have abdominal pain or other gastrointestinal symptoms. They may even have, and this is in its later manifestations, shock or cardiac dysfunction. Intriguingly, respiratory symptoms may be absent, and it's in many instances the case that children are presenting with this inflammatory syndrome soon after they've had SARS-CoV-2 infection, that it may indeed represent a post-infectious hyperinflammatory syndrome. Now, we have seen cases of this, not just in young children, but also in young adults, individuals in their late teens, as well as in their early 20s. It is, of course, the case that children are less likely to develop severe COVID-19. We think that that is because of lower ACE2 receptors, the receptor that lets in the virus, but there's still uncertainty as to why that is. But I think, again, knowing your host will allow you to situate the treatment. Now, here's an important slide that really goes through the spectrum of COVID-19, starting with asymptomatic or pre-symptomatic infection. What this consists of is a positive test, usually a PCR test for SARS-CoV-2, but no symptoms. Mild illness is variable in terms of how it presents, but people can have fever, cough, sore throat, taste and smell disturbances, but typically they do not have any shortness of breath, and they do not have abnormal imaging typically, although there are exceptions. In moderate illness, the oxygen saturation is preserved as normal, but people now have signs of lower tract disease, whether on clinical grounds or on radiographic grounds. Severe illness, now individuals have hypoxemia or extensive pulmonary infiltrates. And then, of course, critical illness consists of respiratory failure, shock, or multi-organ dysfunction. Early data out of China suggested that about 80% of COVID-19 will fall into the mild to moderate categories. About 15% will be severe, and about 5% will be critical. I think that will vary largely depending on the population structure of the country where COVID-19 is prevalent. In older countries which have an older population structure, you may see a different distribution than in countries that have a younger population structure. That brings me to the risk factors for severe COVID-19. I think the risk factor that is far and away the clearest is the age-related risk factor. Older age in every series that we've seen tracks strongly with the risk of severe COVID-19. Chronic obstructive pulmonary disease or other chronic lung diseases, including in a study from the UK that involved 17 million people, severe asthma as a risk factor. Cardiovascular disease, type 2 diabetes, obesity has emerged as a strong risk factor, sickle cell disease, chronic kidney disease, and then being immunocompromised, particularly from a solid organ transplant. Possible risk factors include pregnancy, recent data out of the CDC in the United States. Other immunocompromised states, including HIV, are still debated, and certainly something we could discuss in more detail in the discussion. I think throughout almost all the societies that this is afflicted, there's a disproportionate burden of COVID-19 among racial and ethnic minorities, in the United States among Native Americans, and among the poor. Now, let me now situate our goals of treatment depending on where we are in the COVID-19 spectrum. So before exposure, the goal of treatment is to prevent infection, so-called pre-exposure prophylaxis. Once someone has acquired or been exposed to SARS-CoV-2, the goal of treatment is to prevent acquisition and to prevent disease. This is sometimes called post-exposure prophylaxis. During illness itself, the goal of treatment is to prevent progression, to prevent complications, and of course to prevent death. And there may be, and this we'll learn over time, the potential that early treatment, very early in disease, may prevent transmission. This is yet to be shown, but is something that we look forward to studying. And then following recovery or during recovery, the goal of treatment is to hasten the recovery or to clear the infection. Now, we think that the disease pathogenesis differs depending on the stage of disease. Early in the course of disease, we think viral replication is the predominant driver, and I'll show you some supportive evidence for that and when we talk about treatments. And we think later in the disease, once people are severely ill or critically ill, that inflammation may be have a particularly prominent role. Therefore, the potential interventions that are being evaluated often are thought of in the different phases. So antivirals, we expect, will have their greatest utility early on in the course of the disease. Same is likely to be true for modalities that boost immune responses, particularly those that boost virus-specific immune responses. And then decreasing inflammation, and I'll show you an example of this, is probably going to have its greatest effect later on in the course of the disease. Now let's say a word about antiviral targets. The viral targets, as for all viruses, really depend on the virus life cycle. We know that the virus enters through a pair of receptors, through the ACE2 and the TMPRSS2 receptors. Camostat is a drug that is targeting that particular phase of the virus life cycle. The virus then has to fuse and undergo endocytosis. Hydroxychloroquine is thought to work at that particular stage. The viral protease, a repurposed drug, lopinavir ritonavir, has been postulated to work at that particular stage, although there's little evidence that it is having a clinically beneficial effect, and we can again talk about that during the discussion. And the example I'll give the most detail on is the drugs that target, or the drug that targets the RNA-dependent RNA polymerase, the replicative machinery of the CoV-2, and that's the drug remdesivir. Favipiravir, another drug, also works at that stage. So hydroxychloroquine here in the United States has undergone quite a evolution over the last few months. It started with single-arm or small observational studies that really appeared during March and April, and a little bit before that time. And over the course of the last month to 6 weeks, a number of randomized controlled trials have been presented and or published. And the setting of post-exposure prophylaxis after an individual has been exposed, largely done in healthcare workers. This graphic from the New England Journal of Medicine shows really no difference between hydroxychloroquine and placebo. This particular study had limitations. Most participants were enrolled 3 to 4 days after exposure. And this was done at a time where testing in the United States was severely limited, and only 2 to 3% of people in this particular study had a confirmed SARS-CoV-2 PCR diagnosis. An early treatment study was published in the Annals of Internal Medicine a few days ago, last week. This particular graphic shows you that the time to symptom improvement really did not differ between the placebo group and the hydroxychloroquine group. The limitations of this study include that, again, a substantial proportion of patients did not have a confirmed SARS-CoV-2 infection. And somewhere during the course of the trial, the endpoint was changed from hospitalization to symptom severity score. And then last, out of the UK, a study in the hospitalized patients, the most severely ill patients, looking at hydroxychloroquine versus placebo, showed really no difference between hydroxychloroquine and placebo in these hospitalized patients. This is now as a preprint and more data to come. The US National Institutes of Health has a trial called the ORCID trial, which has also been done in hospitalized patients with hydroxychloroquine versus placebo. The top line results released recently says no harm, but also no benefit. More details to come. That has not been presented in detail. Where hydroxychloroquine in the US is still being actively evaluated is in the setting of pre-exposure prophylaxis. There's a study run by one of my colleagues at Duke University. It's called the HERO HCQ study. Over 1,000 healthcare workers have been randomized in this particular pre-exposure prophylaxis study with hydroxychloroquine. As of a week or two ago, a little over 1,000 people have been enrolled in that study, and I think the results are still pending. Let's now shift to remdesivir. This is a nucleotide prodrug. It's a drug that inhibits the viral RNA polymerase. It acts as a chain terminator. Intriguingly, and this is actually quite interesting, in macaques, which is a model for COVID-19, what remdesivir does is it reduces SARS-CoV-2 levels in the lung, but not in the upper respiratory tract. It does ameliorate disease, and this was a paper that was published in Nature not too long ago. In human trials, the trial that has had the greatest influence on the United States guidelines is this trial shown here. It's called the ACT study. A preliminary analysis that was published in May showed that recovery and people who were hospitalized with COVID had lower tract disease. The recovery was more rapid with remdesivir than placebo, 11 days versus 15 days. The mortality difference was about 7% for remdesivir at 14 days versus about 12% with placebo. That was just, there was a trend, but not statistically significant. What I will say is that the benefit of remdesivir in this particular study is clearest in those who are on oxygen, but are not yet on a mechanical ventilation. I'll repeat that. Benefit of remdesivir is clearest in those who are on oxygen, but not yet mechanically ventilated, really before they get to critical illness. In a separate trial called SIMPLE, this looked at 5 days versus 10 days of remdesivir, and it showed that there was really no difference between 5 days versus 10 days, and so most people here are treated with 5 days of remdesivir. One word about passive antibody therapy. This is the passive transfer of neutralizing antibodies. It can either be convalescent plasma or specific monoclonal antibodies. There was an open label trial of convalescent plasma in China. It was given rather late in disease, about a month after symptom onset, so quite late. What it showed is that there was no benefit in the overall population, but there was a suggestion of a benefit in severe disease. I can say that in the US, more than 20,000 people with COVID-19 have received convalescent plasma. I expect in India, we'll hear some information about that as well. The safety seems to be quite good. Transfusion reactions occurred in less than 1%, and there was a low rate of other complications. There are ongoing prophylactic and therapeutic trials of both convalescent plasma as well as monoclonal antibodies. Steroids are particularly interesting here. As I mentioned before, steroids are being applied later on in the course of disease. This particular study really builds on a long history of controversy around the use of steroids in viral pneumonia and acute respiratory distress syndrome. But because of that hyperinflammatory state that I highlighted earlier, steroids have been evaluated as a potential intervention. And I think the trial that has had the most influence on the US guidelines is this trial here. This is an open label randomized trial among hospitalized patients done in the UK. A little over 2,000 received dexamethasone, a little over 4,300 received usual care. And what you can see is that there was a 17% reduction in mortality. In the overall treatment population, the mortality benefit was most substantial in those people who were on a mechanical ventilation or ECMO. There, the mortality benefit was around 36%. And those people who were on oxygen alone, the mortality benefit was about 18%. And lastly, and this is important, those people who are on no oxygen really did not have a benefit, and one could not exclude harm. And I will reiterate that the use of dexamethasone should really only be in the setting of hospitalized patients who are on oxygen or who are on mechanical ventilation. There may actually be harm in giving it in people who are ambulatory or outpatients or who are not on oxygen. Lastly, treating complications. We've appreciated the role of thrombosis and thromboinflammation. I've alluded to that already. People with COVID-19 who are hospitalized really have a variety of different risk factors for thromboembolism. They have an acute illness, they're often bedridden, they have multi-organ failure. We've touched on, or at least mentioned, the endothelial injury or endothelial dysfunction that can occur. They can have hemostatic abnormalities, including abnormalities of coagulation markers. And the end result is that they have a higher propensity for thromboembolism, pulmonary emboli, myocardial infarction, and in severe cases, disseminated intravascular coagulation. In our institution, our hospitalized patients receive venous thromboembolism prophylaxis, and there are both ongoing as well as upcoming trials of anticoagulation in COVID-19. So let me return to the schematic and situate remdesivir and dexamethasone. Remdesivir a little bit earlier in the course of disease, dexamethasone once people are severely or critically ill. But one point I also want to highlight is most of the trials that we've done to date in the US at least have been focused on people who are quite ill, either in the hospital or critically ill. But as I mentioned at the beginning, most COVID-19 is mild, at least 80% is mild. And I think what this is telling us is that we need to also study not just those people who are quite ill, that's on the right-hand side of this particular graphic, but also we need to do studies in people who are just exposed or who have mild illness to see if we can have an effect on preventing progression, but also could we have an effect on preventing transmission, which would have enormous public health benefits, of course. So here are my final thoughts before wrapping it up and turning it over to the next speaker. COVID-19 treatment requires a multidimensional approach. It really requires an understanding of the host, the stage and severity of disease, as well as the intervention. And depending on the host, the severity of disease, the optimal intervention may actually differ. It may be antiviral early, it may be an immunomodulator later, and it may be combinations in particular settings. The last point I want to make before concluding is we have some really important lessons I think one can learn from HIV. I've spent much of my infectious diseases career treating and studying HIV. I think the pressure to deploy interventions must be tempered by the importance of finding out if a treatment works. Same was true in HIV, same is true in all of medicine. Our guide must be the science. It's going to be an iterative process as it was with HIV. Remdesivir, dexamethasone, these are important advances, but they're not where we need to be. Much more to be done, but we need to build on our advances until we reach a tipping point as we did in 1996 with HIV. And then I think it is critical as we confront COVID-19 to address the disparities, inequities that are revealed by really the twin pandemics of HIV and COVID-19. So with that, I will pause or I will stop and turn the microphone over to Dr. Guleria, and thank you all for your attention. Look forward to the discussion.
Thank you, Dr. Gandhi. There's been a blackout here, so I'm on my phone.
Well, let me step in for Dr. Prabhakaran, who seems to have a blackout in his residence. This is Srinath Reddy here, temporarily substituting for Dr. Prabhakaran. May I now invite Professor Randeep Guleria, who is the Director of the All India Institute of Medical Sciences and an eminent internal physician, internal medicine specialist, as well as a pulmonologist. Randeep, over to you.
Thank you very much. I hope I'm audible.
You're very clearly audible. Please go ahead.
So I'll start with I'll just try and complement and give you a feel of how things are being done as far as India is concerned, and especially as far as the All India Institute of Medical Sciences is concerned. This has already been said that why is SARS so dangerous, because of the fact that the incubation period is from 5 to 15 days, but it can cause a cytokine storm and suddenly to quick death. And the virus can stay on surfaces for quite some time. As has also been said, that we know that there's a whole spectrum of illnesses from an asymptomatic stage, a pre-symptomatic stage, and many individuals in these stages are infectious and can transmit the disease. There has been also various researchers who try to further classify the asymptomatic groups, because some have mild symptoms and are not classically asymptomatic. And then we have the mild, moderate, and severe illness. Here, as far as India is concerned, we have tried to divide them into these three broad groups and have combined the severe illness with the critical illness. But we have severe complicated illness and atypical presentation, which we are seeing more and more in terms of cardiological and neurological manifestations. We have this whole spectrum from a latent period to the infectious period to the period when you are recovered, and the person can be infectious for quite some time, and that is why treating or preventing the spread of infection makes it more and more challenging. As has already been said, we have a whole spectrum as far as the cause of infection is concerned, and as you can see that the virus itself can cause a number of effects. It can cause a direct cytotoxic effect. It can cause dysregulation of the renin-angiotensin-aldosterone system. Endothelial cell damage can happen. It can lead to the cytokine storm or the cytokine release syndrome. And all of this leads to endothelial inflammation, decreased fibrinolysis, increased thrombin production. And thereby, it is truly a systemic disease, as has already been mentioned by Dr. Gandhi. Now, coming to India itself, there has been multiple meetings of the COVID task force and the joint monitoring group, which was formed way back in 2005, when we had when we started working on a pandemic because of outbreaks of what was at that time H5N1, known as bird flu. And this was causing a huge concern that this would be the next pandemic. H5N1 has a case fatality of around 60%. But luckily, this virus did not mutate and did not develop the ability to have sustained human-to-human spread. So the clinical management protocol that was developed looked at severity of illness, and it looked at mild uncomplicated illness, those with mild pneumonia, and severe complicated illness. And based on that, the guidelines actually try to classify for clinicians how to look at the parameters and where this patient should be managed. So if you had a mild illness there was no evidence of breathlessness or hypoxia, your saturation was over 94%, these persons could be sent in what was known as COVID care centers, or home isolation could be allowed with close monitoring as far as these group of patients were concerned. On the other hand, if you had individuals with moderate illness, then these patients had to go to a dedicated COVID health center. And this was that they had features of pneumonia, but they did not have features of severe disease. And here the saturation ranged from 90 to 94, and the respiratory rate was more than or equal to 24 breaths per minute. And there were different criteria for children, which also were used as far as moderate illness was concerned. The severe and the critical was combined, and this was basically those who had pneumonia plus a respiratory rate of more than 30 breaths per minute and a saturation of less than 90% on room air. And these individuals were then shifted to what we called dedicated COVID hospitals. So the philosophy was of having three broad groups of management areas: the COVID care centers, the COVID hospitals, and the COVID ICUs, where patients who needed ventilatory support could be managed. The management issues that we have in a pandemic is, of course, that initially you have what we call the non-pharmaceutical interventions, because these actually delay the disease transmission and outbreak peaks. They reduce the disease burden on the healthcare infrastructure and diminish the overall cases and health impact. And this is what was done in the early stage, because we really didn't have an effective treatment. And this led to the lockdown and aggressive measures which were taken across the world in terms of schools being closed and people not to gather in for various functions. It helped in India because it gave us time. We didn't have a very sharp peak, and it gave us time to prepare for more oxygen beds for the COVID care centers, the COVID hospitals, and the COVID ICUs. Along with the interventions that were put in place was case or cohort isolation. We had quarantine facilities. Initially, we were admitting all patients who were positive, even if they were asymptomatic or mildly symptomatic. Social distancing was done in the form of school closures. Aggressive hand hygiene and cough etiquette measures were introduced, and there were respiratory protection was aggressively done. Very early, we started promoting the use of masks for everyone, and that also did help as far as the transmission was concerned. What was currently not available are effective vaccines or even an antiviral, which has definitely been shown to actually be able to decrease the mortality. In a pandemic setting, you need to look at triage, domestic care, critical care, and hospital surge capacity all need to be established. And that occurs because what we've seen in the past is there's increased apprehensions and increased consultation for respiratory tract infections, including those which could otherwise have been managed at home. And mild cases requiring home isolation also start coming into the hospital. And this actually tends to overwhelm the healthcare system. And that's where the triad system came into place in terms of dedicated COVID hospitals, COVID ICUs, screening areas. We developed our own COVID suspect screening areas, and then a COVID suspect ward and an ILI facility, and also looked at community setting, which could be for as COVID care centers. These facilities need to be identified well in advance, because as the pandemic increases and there's a surge, we need to have these facilities available upfront. And then a triad system, depending on the parameters which we've already discussed. And initially, we also had a history of travel, which is not very relevant now, but history of contact with a COVID-19 positive person, if you're a healthcare worker and you have SARI or severe acute respiratory illness, all of this led on to a suspicion of COVID. And then depending upon the parameters, a decision was taken whether an individual needed to go to different areas and whether he was positive as far as the testing was concerned. So the decision making that was done was looking at the patient's current condition, complications, worsening of pre-existing medical conditions, and other conditions which may be present. And various tools like the Curve 65 or the clinical radiological profile were actually looked at in terms of trying to see how to manage these patients. Often these patients would actually have an X-ray to begin with. And now both the clinician, the radiologist have become pretty good in even being able to diagnose COVID based on the X-ray even before the test results come in, based on the peripheral predominant ground glass opacity, which are actually peripherally situated with the central part being spared as is visible on this X-ray. And different patterns were actually described. Peripheral airspace opacities, lower zone consolidations, peribronchial consolidation, focal airspace opacities, and we had even saw some nodular mass-like opacities, and diffuse mild, mid and lower zone consolidations. And then there were rare presentations which we don't usually see in the form of cavitation or partial collapse. So this is just to give you an idea of the type of X-ray pictures that we do tend to see. The classical one, the pattern one, which is the perihilar consolidation, but you can get low lobe consolidation or peribronchovascular consolidation, or you can get a lot of ground glassing, and the pattern 5 actually tends to show the rounded opacity that can also happen in patients who are COVID positive. And these are all patients that we've seen in our hospital and turned out to be COVID positive. The CT scan was also used extensively, and we converted our trauma center into a COVID hospital. And that CT scan in that centers were used for doing scans for these patients. And also in the non-trauma ER, we were doing CT scans. It's important to remember that sometimes the suspicion may occur as far as CT scan is concerned. This is one patient we had who was a 30-year-old female presenting with fever and cough for 2 weeks duration. Her test RT-PCR was negative initially, and she could have gone into the general ward, but the CT showed these classical Étoile sign, which is this reverse halo as we call it, and this led to a suspicion of being COVID positive, and a repeat test showed that this patient was positive. So I think at times if your RT-PCR is negative, you must look at the clinical radiological profile, and based on that take a decision, because we've had cases where the patient has been negative and been shifted to the general ward, and subsequently we've had a little bit of an outbreak among healthcare workers in the ward because it was not suspected to be COVID positive. This is another patient who was actually a 54-year-old male with fever and dyspnea, but RT-PCR again in the initial part was negative. But if you see the CT scan, it shows these classical ground glassing, which is at the periphery and around the fissure also. Again, a very classical CT for COVID-19. And therefore, one has to look at the entire clinical picture as what clinical medicine is all about, rather than just rely on the test in terms of making a diagnosis of COVID-19. This is for another patient who had this classical features, and you can see these classical ground glass shadows, which is a classical sign that this patient has COVID-19 infection. So managing mild cases that we had, we did not require hospital admissions, and we were looking at whether isolation is necessary to contain the virus. And because of that, in the early stage, when the numbers were small, we were admitting them in hospitals. But subsequently, the hospital was mainly focusing on more sick patients, and these patients were either advised home isolation or were being sent to non-traditional settings like stadiums, auditoriums, or what we call paid facilities, where certain hotels were converted into isolation facilities for positive patients. And this became important, but it was important to educate these patients about the warning signs, which meant that this patient who had mild illness could deteriorate and have a severe illness, which was trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse, and bluish lips or face. And this, along with any other symptoms, were something that we did. Subsequently, the government actually distributed a large number of portable pulse oximeters to all these patients who were on home isolation to monitor their oxygen saturation, and a healthcare worker would actually ring them up twice a day to find out what their saturation was, because it was observed in one of the data analysis that we did that a number of patients who were not wanting to come to hospitals were coming very late, and this was leading to a higher mortality in the first 24 hours. In mild illnesses, a large number of things were used. We still, in certain centers, continue to use hydroxychloroquine along with antibiotics and hydration. There is a group in Mumbai that uses a combination of ivermectin and doxycycline, And they, in their study, find that this combination is also very useful in mild cases, because both hydroxychloroquine and ivermectin, which are repurposed drugs, have been shown in laboratory data to actually decrease viral replication. And therefore, there may be some role as far as these drugs are concerned. A detailed protocol for home management was made by the Government of India. All of us were involved in this. And this looked at how a person should actually home isolate himself in terms of various things, the do's and don'ts that need to be done, both for the patient, for the caregiver, to prevent this patient from deteriorating and from the infection happening in the community or to other members in the household. Those criteria were also actually put in place. This is a very busy slide. I just don't want you to look at it in detail, but this is just to give you this guidelines which we have put up, which is basically that you have these mild cases, moderate and severe cases. The focus in mild cases has been just symptomatic treatment and hydroxychloroquine. In moderate cases, oxygen therapy and anticoagulation has been the main treatment strategy, and this is in prophylactic doses. Plus, if the rose or the steroids is the other thing that has been added. In more severe cases, we have now found that high flow nasal cannula and non-invasive ventilation actually helps. Many patients, one was able to manage with conscious proning and CPAP and high flow nasal cannula without having to intubate them. And we do continue to give methylprednisolone, but we hike the dose of oral of the anticoagulation to therapeutic dose. And then in cases who require intubation, ventilatory strategy is given. As has already been mentioned, remdesivir is given early because if it's given late, it has less benefit. And normally if the patient deteriorates, his saturation is less than 94%, he's showing increasing infiltrates in the lung. And it's usually the 5th to 7th day that we would recommend patients be given remdesivir. Giving it much later has actually not shown much benefit, and we also give it only for 5 days. A convalescent plasma is something that is very popular in India, and there are plasma banks which have been set up. But I still feel that we need more data to really show how effective it is. And there are some studies, there's a study from the Netherlands which shows that if you give it late, then individuals already have good amount of antibodies in their own blood, and giving convalescent plasma is actually not that effective. Anti-IL-6 drugs, tocilizumab is another drug which is popular in our country, both that and a new drug, which is the DCGI, the drug controller has given permission, which is itolizumab, which is a drug used for psoriasis and is also an anti-IL-6 drug. But this is given for cytokine storm. So if your IL-6 levels are very high, if your D-dimers, your CRP and ferritin levels are really high, they are given to some of our patients. But these are double-edged swords because they can lead to superadded bacterial and fungal infections. And we advise caution as far as their use is concerned, but they are being used extensively in the private sector as far as managing these patients are concerned. Finally, just to give you a little overview of what we did, when we had the pandemic, we quickly realized that we're going to need a huge capacity, and therefore we converted our National Cancer Institute, which is a 700-bedded hospital, but had just started and we had just about 100 beds operational, into a COVID hospital. We also converted a trauma center, which is about 250 beds center, into a COVID hospital. The National Cancer Institute was looking after these mild cases, and the more severe cases were being looked at at the trauma center, but this difference actually became less with time. And we, till 10th July, had seen almost 4,500 patients in different areas. This has gone up to more than 5,000 right now. And this admission was both in the National Cancer Institute and the Jayaprakash and Ryan Trauma Center. Treatment protocols varied. We used, depending on the time and the literature, from hydroxychloroquine, azithromycin, doxycycline, ivermectin, steroids, multivitamins, low molecular weight heparin, and then the specific treatment like plasma, remdesivir, and tocilizumab. Conscious proning was something that we aggressively did and found that it was quite effective. As has been shown, comorbidities was found in a significant number of our moderate to severe patients. If we looked at the data from 990 patients, almost 727 had comorbidities and 336 had both diabetes and hypertension, hypertension being common as a single comorbidity. And then we had a number of patients with malignancy, and they continued to be positive for a long period of time. CKD patients, and they needed dialysis, and again, for a long period of time, their RT-PCR was positive. And we had also patients with chronic lung disease, And recently our center has published a paper where we've shown that CLD patients actually tend to do worse if they get infected with COVID-19. As far as India is concerned, there was some data that came up from the national registry also, and it also tended to show that your case fatality rate actually increased significantly, almost by 3 to 10 times, if the age went up and the comorbidities also became there. So if you were, say, in the age group of 60 to 74, without comorbidities, the mortality was almost 6.55%, but it went up to 25% if you had associated comorbidities. So there was a direct link which was seen between the increasing age bracket and the presence of comorbidities. And that's why it became more and more important to really address treating and managing comorbidities aggressively and admitting these patients who had comorbidities even if they had mild illness. The demographic profile of the 3,000 patients that we saw in the National Cancer Institute showed that most of our patients were between 20 to 60 years of age. We had a child of 1 month old who was going out to be COVID positive, and there were challenges every day. We had children whose parents were negative and the child was positive, and how do you manage this patient in a COVID ward where attendants are not allowed? We'd had to do multiple deliveries, cesarean sections, and we've had an elderly also who actually was discharged successfully. Most of our patients who had infection were close contact or came from hotspots or from containment areas. We had some healthcare workers, but majority of them actually got it from outside because many of them were staying in areas which were containment zones. About 5 to 6 of our healthcare workers got the infection while they were working in the COVID center. We looked at various factors. We looked at the concerns that the healthcare professionals had who were managing COVID. And most of them, the concern that they had was risk of infection to self or family. And this led to a major worry among them. And it needed a lot of counseling as far as the healthcare workers were concerned. And there was also disruption of daily activities. We also had a questionnaire which we gave to around 311 individuals after discharge, because a lot of stigma has been associated with the disease. And patients were really reluctant and hesitant to come to hospital. 66% actually hesitated to inform their family and friends about their disease because they felt it would sort of ostracize them in the community. A majority felt ashamed, guilty, and worthless, and many felt discriminated, and more than 70% felt discriminated by the neighbors. Interestingly, almost 2.4% of people who turned out to be COVID positive were actually fired from their work because of the fact that they were COVID positive. So there is still a significant amount of stigma and fear which is associated with this disease. And very early we realized that there is something more that we need to do just than managing our patients. And we did that, and I'll come to that. This is a chart which is a little old, but this tried to look at a scoring of various drugs which are available in India and how useful they would be. This looked at drugs like chloroquine, hydroxychloroquine, remdesivir, lopinavir, favipiravir, because favipiravir is now available freely in India. It also looked at ivermectin and a lot of other drugs which are being looked at for their antiviral potential to see how useful they would be as far as India is concerned. We also did a study where we looked at, and this has been shown by a number of papers, that the RT-PCR positivity does not imply infectivity in patients who have recovered. And this is something that we should remember, that you shouldn't, once a patient has become all right, a positive RT-PCR may just be the virus which is being excreted, but it is a non-viable virus and does not really mean infectivity. And that led to us to change the guidelines that in both asymptomatic, mild and moderate disease, there is no RT-PCR requirement before discharge, which was something we were doing before. And if you have a person who is asymptomatic for 10 days and has no symptoms for 3 days, he can be sent home, and the chance of him being infectious is very, very low. So we changed our guidelines based on the recent data which had emerged. We also did a lot of activities, and I'll quickly run through them. We had information booklet. We started a COVID portal. We had COVID videos, webinars, training of national at international level and national helpline and guidelines. This is an information booklet which we made way back in March. We started a COVID portal to increase the information among healthcare workers. A large number of videos were prepared, more than 40 videos on various topics, and these are available in the ministry website and on the AIIMS website. We had webinars, and we really taught not only our own residents and nursing officers,